kicking. Are you graduating your seniors?
They have 3 weeks, so maybe, but maybe.
I'm looking at them. They look very tired.
Yeah,
Looks like
they're
you're
they're
working them
they're
hard.
working very hard.
It's
Yeah.
6 p.m. Come on, guys.
They should be on the golf course and they're not because they're here for Cobra.
All right. Excellent. It looks like you can't, your first year fellows have to just squeeze together in one room. Okay, that's good.
Basically.
That's awesome. Clearly that West Coast pay is plenty for that
Yeah, they
trailer.
have one phone for all four of them. They just pass it around.
So what are we doing today, Prithvi?
So tonight
Let's
is
get to
senior
it.
send-off. So we have our four senior fellows who have been with us for 2 years, showing us some of their most interesting cases. Maybe not like the weirdest zebra of cases, but I think ones that they've put a lot of effort into and have seen through. So we will learn from them, and we have our usual great faculty of Cobra attendings from the Cleveland Clinic and from Stanford. So we can go whenever you say, Dr. Srivastava.
I think let's do it. Special thanks to Bausch again for supporting us through the Cobra series. I think it's Stanford first, Prithvi. Who do you got?
Jonathan Lin is up first. So Jonathan did his residency at the Mass Eye and Ear, has been a fantastic fellow with us, and is going to go back to the Mass Eye and Ear Infirmary as a clinician scientist come the summer. So Jonathan,
Congratulations.
yeah,
Awesome. Good
congratulations.
work.
Thanks so much.
Congratulations.
These snakes are getting scarier as we go, and then further from cobras as species as possible.
Well, thank you so much for this opportunity. It's kind of can't believe this is the last Cobra, but I hope to do it justice. So this is a case that I did with Dr. Ahmad Al-Mujahid, and it's titled "A Herculean Effort."
You're allowed to come
Um,
back, Jonathan. You can come and watch,
Yeah.
that's true. That's
participate.
true.
You're allowed to.
I would love to. Yeah, yeah. So this patient is a 62-year-old female who presented with eye trauma to the left eye. She was unfortunately the victim to assault by a known assailant in a grocery store. It's fist versus eye, and unfortunately, the assailant was observed to be wearing rings. She initially presented to the outside hospital, and you can see, CT scan shows clearly the left eye, disorganized globe, very concerning for an open globe injury. At the time of her initial presentation, she was bare LP in the left eye. Unable to visualize the pupils. IOP was deferred at the time, unable to do visual field confrontation. And she underwent a zone 2 globe injury repair by one of our excellent residents, Anna Toth, as well as one of the globe fellows, Blake Schneider. In the operative report, you could see that there was a full thickness scleral rupture that was observed extending from approximately 10 to 2, adjacent to the limbus, and unfortunately, there was noted to be significant prolapse uveal tissue. This wound was closed with approximately 10 simple interrupted no nylon sutures to close the area. And so at post update one after globe injury, her vision remained LP, IOP of 8. So the globe was formed, fortunately. A week later, revision remained LP, IOP was 4. And that time, the B scan was performed by the postoperative team and was noted to have non-appositional choroidals and a funnel retinal detachment. The patient then was referred to the retina service for further management. As we know, these cases are very complex, and so really takes a true hero, a true Hercules, to really to address these cases. And so, fortunately, this patient got to see our own Dr. Al Mujahid for the next steps. So the patient was finally seen by Dr. Al Mujahid post-op week 3 after the initial globe injury. You can see on the B scan here very clearly, kind of a nearly closed funnel retinal attachment, and you can see the retina is being kind of likely incarcerated toward the site, kind of superiorly of that initial injury. Vision remained LP at this time, and there was a very extensive conversation between the patient, Dr. Al-Mujahid, about kind of risks, benefits, expectations, alternatives to surgical approach. Obviously high risk for recurrent retinal attachment, high risk for, accelerated ptysis, high risk for having no, kind of visual benefit. But after extensive discussion and kind of I think pretty clear expectations, the patient was very understanding of the situation. The patient really did want to try everything possible, and so she requested to proceed.
Is there a choroidal there as well, Jonathan?
Yes, yep, superior kind of choroidal, exactly. Yeah.
Do you think that's a cyst in the retina, or do you think that's just that kind of hypoechoic area kind of within that space?
Yeah. Yeah, it's hard to say for sure. I think it probably is maybe like an area of openness, and there's kind of, as you'll see as we show the video, there is something encircling the retina there that may be kind of pulling it together. And
Hmm.
so I think there's kind of maybe an area of openness and then an area of kind of closed, tight adherence there.
So, a question to the faculty: open globe injury at the time of injury and closure, putting a scleral buckle.
It's your favorite question to ask.
Yes, no, maybe. Carolyn?
I'm the only faculty on, I think, right now. Well,
Multiple
I think
faculty.
I think the problem is retina specialists aren't usually the ones closing these globes primarily. And a scleral buckle, while not technically hard, if you are not used to doing scleral passes regularly, you can actually cause more problems. And then also there's like a little finesse to putting a scleral buckle in. I think even when I was teaching the course last weekend, the rising fellows, they don't understand that the buckle doesn't just like, you don't just tighten the buckle to strangulate the eye. They didn't quite understand about like imbrication and all that stuff. So I just think, yeah, I mean, depending on what the globe looked like, if I were the one closing it, possibly, but I don't think it's routine, and so that's why it's not standard of care. But I think it is certainly an option. Colin McCannell at UCLA, he made the residents do that for all
Mhm.
Zone 2 open globes that they fix on their own at Harbor.
Yeah,
Yeah.
So
I
wishy-washy
remember,
answer for you, Prithvi.
Yeah, thanks.
I was Berta and I met some of our Japanese colleagues at a meeting, I think last year, and they were telling us when the retina service, I think they do all the posterior globes, and they routinely put buckles on every single one of their globes. But it's a retina specialist, so they're very accustomed to doing so.
Yeah, I mean, I think as Carolyn said, if you are the retina specialist and you are able to, and you're there anyways, and the eye isn't a complete mess at the time of primary closure, it's harder to get that buckle in with all that scarring the next surgery. So that would be the only like advantage, knowing that you've closed it. Maybe there's a fighting chance, but then you'd like to have the buckle. But if it's a really bad looking injury, then maybe you would do your fixing without needing a buckle anyways. So just something to consider.
Definitely.
I would argue for a case like this, closed funnel, you probably don't need a buckle, but you would not know that ahead of time, right? As you're closing the open globe. Um, but I agree with what Caroline said that as a primary globe, closing team, if they're not, if it's not retina closing the globe, they might not be comfortable placing a
Yeah.
buckle. And I think you do whatever you're comfortable with.
Yeah. And the
So
eye's soft and like, you
yeah.
could over tighten it and like all these things. So, yes. All right. Jonathan, surgical plan.
So yeah, surgical plan. So by report, it was unclear the location of the lens, and so it definitely was not visualized at the time of our exam. Per talking to the globe repair team, there was a lot of prolapse uveal tissue, some of which had to be cut, some of it had to be removed. Lens may have popped out at some point. So surgical plan, 23 gauge to give us kind of the possibility if we need to do lensectomy. This is reasonably young patient, so that would have been possible. I think given the I think almost certainty of needing to do a 360 retinectomy, as well as I think the kind of understanding that it would probably be nearly impossible to get back far enough to do put the buckle given the scarring. Did not elect to place a buckle, but so, the idea was to, get in, clear the view, see what we're dealing with, peel membranes, flatten the eye, put oil. I mean, kind of a lot of it was kind of depending on what things we're seeing. I think the patient, understood that if we got in, it was just like too much to handle. We're going to do only what was like safe. And so, but that was kind of the initial idea going in. We did do, I believe, methotrexate infusion, kind of would give a high risk of PVR in the context of trauma, as well as a plan for injection at the end of the case, if the retina warranted that. All right, so here we go. So 23 gauge system, we've done a partial peritomy here. going quite anterior. You can see kind of aiming everything up towards the kind of towards the where the lens would be to kind of avoid hitting any retina if things were being pulled forward by any anterior PVR. Starting to clear away, blood, kind of this fibrinous membrane. Pretty clearly, you can see there really isn't a lens back there, and then we can rapidly see this closed funnel retina being pulled towards the superior wound here. And yes, that is choroid. So we're kind of getting a kind of a lay of the land. We can see that the retina is, pretty much nearly closed in a funnel. There seems to be some sort of PVR membrane kind of enveloping, the portion of the closed funnel, which is what kind of I was alluding to Dr. Shrivastava in terms of what that cystic space could have been.
So, Jonathan, any thought at this point while you're playing it, like what would tell you to stop?
Yeah, I think seeing the retina in this configuration was definitely a first. So that was in and of itself nearly enough to cause me to think we should stop. But no, but I think really the idea was to kind of get an idea of what I think one of the possibilities is that as we were kind of bringing the retina out of the incarceration sites, I mean, it's possible we could have caused a lot of bleeding with unclear source, choroid, ciliary body, retina. I think if there was kind of constant hemorrhage and we weren't able to stop, that would be one kind of situation in which it wouldn't have been safe to continue. Fortunately, that didn't happen, I think that would have been a kind of possibility there. So here, we're trying to case. I think we're highly suspicious that there's part of the retina that's incarcerated into that superior wound, and so we're kind of very gently trying to peel away the retina, kind of peel it away. Pretty quickly, we realize that it's pretty tightly adherent there, and so kind of are resorting to diathermizing as anterior as possible, and then kind of planning that 360 retinectomy. So here we are, slowly, cutting away and then trying to be as meticulous as possible with endodiathermy to make sure we don't, cause, too much bleeding that would impede our view.
So Jonathan, if you guys thought that there was a napkin ring PVR there, why didn't you just peel that first before doing all this anterior stuff?
Yeah, that's a good thought. We didn't actually think. I think our first idea was kind of get a sense of what the rest of the retina looked like, but that would have been, I think, would have helped with counter traction. Fortunately, that those napkin ring things actually came off pretty easily in the end. But yes, that would have been a nice thing to probably try. So you can see here is kind of that napkin ring that we're peeling off. Fortunately, actually, I think there was, this patient came in, kind of maybe a few weeks later than we would have maybe wanted to see her. But I think that one potential benefit of that is that the PVR kind of had matured, and so it was a lot easier to, I think, peel, and it was more substantial to grab at the stage. So
And then
let's peel that.
is the retina like 360 of it detached anteriorly? So it's just like doing
It is
this.
now. Now it's just kind of flapping
Yeah.
around. Yeah.
Yeah. So I don't like doing that.
Yeah.
What would you do differently, Carolyn?
Yeah, so I would have peeled the napkin ring first, and then like the whole retina, so like the inferior part of the retina is, and the superior is all going through that superior wound. So I would have then diathermized just the inferior part. So then the superior is still tethered to where it is. And that way you have counter traction, and then you can then peel everything on the inferior retina, kind of open that flower up. And at the very last is segment that peninsula or that peduncle to make it a full 360.
Got it.
A real third hand.
Yeah.
Yeah, that's a good idea. I will say it was, maybe partially due to my limited experience with these kinds of cases, but I think it was sometimes hard to distinguish what was what. Everything was kind of pulled into a very small space, and so I think it would have been possible that even if I had tried to do that, I may have accidentally gotten some of the wrong half of the retina potentially. But so here we are basically, now that we have this kind of free floating funnel, closed funnel, we're kind of basically using visco dissection with visco to kind of just trying to open up this funnel gently. And you can see, fortunately, we are able to kind of get things opened up a little bit here. We can sort of see a glimpse of a nerve back there. Just additional visco dissection to kind of really get this opened up as wide as possible. You can sort of see like, kind of a glimpse of what looks like probably the, foveal light reflex, macula area.
Is there a lot of vitreous in this?
It doesn't not. I mean, I kind of have omitted some of the parts where there's kind of some vitreous being removed. There wasn't like as much as we maybe thought we would have encountered back here.
And is the plan to use perfluorocarbon at some point? So how do you balance the Helon versus perfluorocarbon story?
Yeah. So I think at this stage we were still relatively early in the case. I think our goal was to just kind of get things open, so we have a sense of kind of the real estate we have left to deal with. I think then kind of likely extend, kind of extending the retinectomy. And then I think the idea was that once we were happy with how things looked, then try to, use fluorocarbon to flatten the retina to see if it would flatten, and then kind of go from there. So, gently using the soft tip, cannula to kind of open up, kind of spread out the retina, try to get rid of some of the folds. And so, here, as I alluded to, kind of getting a better sense. Now we're going to use some PFO to kind of flatten the retina and see kind of where we stand. You can see there are areas on the periphery that remain, kind of very stiff, and appear generally unhealthy. And so these are areas that we're kind of trimming away using diathermy for hemostasis.
Alex, how do you decide whether to make a radial cut in some of these 360s or like, very posterior 180s in order to flatten? Any tips on that?
I, so radial incisions, I don't typically use, but it looks like it's flattening out here. I try not to make too many cuts in the retina if not necessary, but if it does look stiff in one particular zone, I look to see if I can make a relaxing, like maybe like a more like a V-shaped
Mm-hmm.
incision. Just focusing on the area of fibrosis. I mean, I don't think I would have made any radial incision or additional incisions here. I would just try to flatten it out
It
and
looks pretty smooth.
yeah,
Yeah, he's doing great. You got it.
yeah. I think it looks great.
Yeah. So at
Wrist
this
count
point,
fingers. Wrist count fingers is what I'm looking for.
yeah, exactly. So yeah, fairly happy with how things, flattened out. So, 360 laser to the retinectomy edge here. So basically at this point, basically since this patient is functionally aphakic and basically aniridic at this point, the decision was to place iris retention sutures. And so there was a nice technique described by Dr. Christina Wang, which she does kind of like a star configuration with the 9 proline suture on a CAF needle. And so that's the approach that we chose to do here. So you can see here we are using this needle and then docking into a 25 gauge needle and then pulling it across. And it forms kind of like basically a 5-point star configuration. One of the nice things about, one of the advantages of the star configuration is that you get a lot more kind of spaces for relative to the number of kind of passes across the eye. And so it has, kind of more bang for your buck in that context. And so, here we are tying it down.
I have a question for the faculty. Has anyone seen these sutures actually work? I mean, I've placed a lot of these in the past, and all it really does, in my hands anyway, is cause a lot of fibrosis to form. Sometimes the oil can still come through. I find that in these cases, if you underfill, with a 360 retinectomy anyway, you oftentimes don't need a complete fill, and I find that just underfilling the eye sometimes is helpful enough to prevent the oil from coming into the AC.
Yeah, I agree with you, Alex. I used to put these in and now rarely do. And I agree. I just fill it up that I know that my inferior retinectomy will be covered. You do get more emulsification and underfill. So like there's less, you can't wait forever to take the oil out again, but at least throughout the first couple of months, you have a clear view. You can see if there's any early PVR, and then you schedule to take the oil out after.
Yeah, I stopped doing them as well. It's a pretty technique. I mean, I think it's pretty cool when people talk about them and everyone gets excited, and it's always the younger people who do it. And then as you've done enough of them, it just there's so many other dynamics going on here. So yeah, I tend to just put the oil in and try to
It's
take
an
it out.
important thought, though, right? Like, you're recognizing that if you didn't have anything there and you try to fill with oil, then, it can come forward. And I think the one time that I would do it is if I was very sure I wasn't going to go to air and then I was going to do direct PFO oil
Mm.
exchange. Then it's hard to underfill that, right? Because then you'll leave perfluorocarbon behind. So, yeah.
Perfect. So here we are going to air.
This is where like I watch to see whether those edges start to curl up a little bit as the
Mhm.
fluorocarbon goes away, and that's where sometimes a little bit of a V, like Alex pointed out, or something like that can be helpful.
Yeah.
Yeah, Priti, do you tend to dry along the whole 360 edge when you do this?
I would do a direct PFO oil exchange.
Yeah. If I do it under air, I really slowly dry the through whole 360. I just walk that soft tip around.
But by this time of the case, hours into it, I'm like ready to get out.
Mm. Indeed.
That's
Closing up shop here.
Winning. This is great.
yeah.
Intravitreal methotrexate there.
Did you treat the patient post-op as well with?
Yes, so they're getting basically guard trial kind of timing of methotrexate injections at this stage. So still pretty
Alrighty.
early in the course, but week one after detachment, this is what she looked like. No
Dang.
CTs over here. Vision was 2400, aphakic under
Woo,
oil, IOP of 10,
nice.
which I think was more than we'd expected. She's about a month out now, so she remains count fingers. She has developed quite a bit of kind of fibrous membranes along the retention suture plane, which is kind of what
There you
we
go,
expect to see.
Alex.
But yes, that is, I think, what they were discussing. And then IOP of 6. So she remains getting, the plan is to get the full kind of 3-month course of methotrexate injections per the guard trial. And then we'll see kind of how she does. And I think she's very realistic about kind of expectations. So she's not like, she's kind of very reasonable in terms of that. So this is kind of the retention sutures there. So I just wanted to quickly give an acknowledgement to, of course, our amazing program director, Prithvi Sanjaya, and then especially Dr. Al Mujahid for his guidance during this extensive case. It feels crazy to be at this stage, finishing fellowship in just a few weeks. And I've been very lucky to have an excellent, kind of team of teachers, surgical teachers here, including many the Cobra folks, Dr. Pan, Dr. Rahimi, as well as amazing co-fellows, both the ones my former senior fellows, as well as my current junior fellows, and then of course my co-fellow Bertan, who we've been together for now almost 6 years. So it's going to feel a little weird to be moving different places, but I'm sure we will be in touch all the time.
Very nice.
Congratulations. Nice job. Do you have to make Prithvi's picture the biggest? Is that just part of it?
It's in his contract.
I'm surprised the watermark isn't on there. Great job. Congratulations, Jonathan. The ambassador is gaining someone excellently well trained. Good for you. We're going to lead off in the Cleveland side with Joe Abraham. It's hard to believe. I mean, I've known Joe for a long time before his residency, during his residency, and to see him finish up here as fellowship. We're really proud of him. He's going to the Ohio State University, where he'll be practicing and joining faculty there. Joe, take it away.
Thank you. It really does feel surreal for this to be the last presentation in all of fellowship, actually, for me.
No, you
Uh,
got 3 more left next week. Just so you know.
Not just because I said that. So we do have a lot of diabetics in Cleveland, so I'm presenting another TRD repair with some more instrumentation used this case. So briefly, we had this 44-year-old male presented um, with PDR, presenting with acutely worsened vision. He'd been monitored for peripheral traction, and then went MAC off, count fingers vision, has very early cataract. Prior baseline vision in that eye was 2100, had some macular ischemia, but did plan to go in. I don't have a fundus photo. This patient was seen at the satellite, and they didn't get it that visit. So our plan was for this MAC-off TRD that was essentially 360, except for the areas that had prior PRP, was to do a bit with membrane peel and laser. The cataract was very nascent, so decided to forego doing a phaco here.
This was previously treated. Sorry, Joe. Did you say it already had some laser in or
They had
no?
some laser, yes.
Yeah.
Yes.
And
Not
was
complete.
yeah, was he getting already some anti-VEGF prior to this, or did
Yeah,
you
he
know?
was. He'd been lost to follow-up about 4 or 5 months before this acute presentation,
Mhm.
but he had, a long series of treatment.
How, how many anti-VEGF right before the surgery?
So the patient presented here in January, and then there were two Avastins before the surgery.
I like it.
Although, as you'll see, maybe it wasn't enough.
Okay, should have done more.
So we're gonna come in and we see, a pretty broad uh, TRD there with the borders essentially of the PRP, at least superiorly. So just relieving the anterior posterior traction, using the uh, triescence to help visualize those areas that may have been a little bit more skytic or plaster, not completely separated. So then, at this point, trying to get the posterior highlight off the nerve here, which was, initially proving a little challenging, so decided to make a bit more space um, with the cutter there, opening up some potential planes there. And so now we're going to go in and lift it off, just not too far though, because everything's under significant tension.
Hey, Joe, so stop for a second. How you said not too far. How did you decide that? I mean, obviously you've done this a couple of times. What have you learned now, 2 years in? Sometimes you just get so excited to pull it off. How do you now know when to let go?
So I feel like I go by how much tension and lifting is occurring in the tissues around. And I also like try to assess what is the kind of the health of the tissue that's having the traction. As you can see on this retina is incredibly ischemic, and I'd be a little more nervous about pulling on that in terms of potentially any iatrogenic complications there. So the goal was to just get it off the nerve and then segment/delaminate from there.
Yeah, I think it's a good point to like look beyond just where you're pulling, which is something I think you kind of pick up and nuance as you get farther along this.
So we're going.
Sometimes, and Asan's talked about this in previous Cobras, too much triescence at that point can sometimes occlude your view of what's happening, especially nasally. So, like if you think you're going to go for the forceps move, or your next step, whatever that may be, you sometimes have to clear like you have that triescence out of the way. Otherwise, you think you're making the right move, but then you just can't see anything. It's just too much. Do you dilute your triescence, Joe, or are you going full strength?
One and three.
Prithvi, to that point, if you look at what he was doing here, I think really nicely, you could see the triescence actually illuminated that the highlight wasn't, the peripheral highlight at least was still in his way. So whenever he went down with the forceps, at least he could see what he needed to clear a little bit. So yeah, I know there's this balance of trying to figure this out, but I think it gives you, you don't want to go too early, but you want to go at some point in time so you understand how much of the highlight is still down.
Did
I
you
also
uh,
feel
did you
like in
change your lens also? Did you because your view looked a little different? Did you go to the green or?
Yeah, we went to the green for the lifting off the nerve there. Sometimes I find with phakic patients too, I like a little bit extra staining, just because the lighting visualization is not quite as good as pseudophakic cases.
Hey Joe,
So
question for you. You know, when you're in the attending chair, and I've commented on this, one of my learnings. I feel like I pushed too far, and in hindsight, I kind of wish I just switched to bimanual earlier in these cases. Like, do you think that'll be something you're proactively thinking about in these cases? You're gonna just try to get it all done with a cutter when it's just you.
you're prescient in your comment there. Um, I think that I will give the cutter a go, especially if I know it's going to be a tricky TRD. I'll prefer to do 27 gauge cutter just for that extra, nimbleness. But I think if it's not coming easily, I would just I wouldn't hesitate to put the chandelier. I don't want to be putting a chandelier in like 1.5, 2 hours into a case if I think that it's gonna benefit significantly from that. I'd rather put it in fairly early where I can see the most benefit from it. Um,
I feel like our fellows have kind of morphed to predominantly, going for that pull with the forcep, like when they can, versus, just with the cutter. I don't know if that's the same vibe in Cleveland. I mean, it depends case by case, but they more and more so going for the release at the nerve head.
And so I think how we're all taught, if you didn't know don't know where to start, it's a good place to start, right? Go right to the nerve and work your way out.
so here we're tackling all this uh, nasal uh, fibrovascular proliferation there. So we're gonna continue to segment carefully, trying to avoid making any breaks, but trying doesn't always succeed.
I guess you're about to tell us something that's about to happen.
Well, to mention the bimanual piece, I'm pretty sure it's about to come in here. Yep, so here we go. So we're putting in the chandelier. Like we're gonna make this work. And then immediately, first maneuver. I should have slowed that down more, sorry. But lifted up a little bit and then
Yeah.
snipped snipped
Yeah.
some
So
energy.
So it
yeah,
look.
would you? Yeah, go ahead. Sorry, please.
Oh no, I was just gonna ask. Are those the horizontal scissors that you
They
have there?
they are the horizontals, yes. I
So yeah, I think you have to be careful when you do a bimanual technique with these horizontal scissors. They're quite sharp, and you really have to you know ha, ha, lift and carefully dissect off the membrane before you actually do the cutting. I actually like the vertical scissors because you can use them like a pick to really get your plane before you cut. So a nice pair of vertical scissors I actually find really helps in these cases.
oh
It's
yeah,
funny, Alex,
absolutely.
that you say that if we use the Alcon horizontal scissors, like I find them not sharp. They, one blade has a little bit to the other one's blunted, and I find that it's more of like a probe sometimes than an actual cutting device versus the verticals. I think are sharper, and I like the sharper ones.
So we're conceding on that little area for now. Live to fight
Nobody look
another
So
over
you
here. We're
day.
gonna
you
go
saw the
somewhere else.
blood and then you just went somewhere else. But you like for
Thought we let it
our
settle.
rising fellows, like did you like increase the pressure? Did you like
Oh
wait a little
yes,
bit? Did you
yes.
thought about diaphragm?
And we went to 60, but was also concerned about the perfusion. Obviously, this eye's super ischemic at baseline here.
Mhm.
And then there was like some soft tip action to clear some of the blood, but it did reaccumulate a little bit here.
Yeah, it looks like you
So
nicked another vessel on this side too, right?
also
Oh,
in
Which
your
is
mind, what's your endpoint?
so the endpoint here was there's so many. I mean, obviously, the AP traction is released and the traction off the nerve is released, but there's so much radial contraction with these other areas of fibrosis that we did want to release those before calling it a day. But that in some of these TRDs, that is a uh, definitely knowing when is enough, like how much segmentation I feel like is a nuance you pick up and as you do more of these kind of cases.
I mean, it looks like the on the macula side, you've released a lot of it. This is all nasal. Um,
Yeah, that's
I,
fair. And I guess that, as Dr. Sears likes to say, don't lose in the nasal retina. Um,
I think superiorly it's still detached. Maybe that's what you're worried about.
yeah.
Yeah.
So we did use the vertical scissors as well to try to uh, create a new plane for us to put our cutter in. And tried by manual again here. And it's hard to see there, but there is a little snip iatrogenic break there underneath that, which we use the drain from. So
I'm not sure you can always help it, Joe, and I think that you recognize that as well. I think sometimes the anatomy is as it is, and you just have to get the traction off it at that point.
Yeah, I think
yeah,
more is what's the implication of when you get a break, what do you have to ensure you're doing and you're doing it there. Now you got to take all the fibrosis off.
Yeah, can't stop now.
I also find making sure you mark the break here really well because it gets hidden underneath the blood sometimes.
yeah, that was definitely something that we'll be more mindful of because it was a
And
bit annoying to find.
sorry, to Alex's point, you can even if you stick with the curved horizontal scissors, like you can still use that as a probe, especially since you're reflecting with your other hand so well. Like you can get in there and kind of separate space and not have to be like actively cut, cut, cut all the time. It could be spread, 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 and then cut selectively. That
Almost like a pick,
like a
essentially.
spatula pick, yeah.
Yeah,
So like, I feel like those moves are probably more important as you're finding where to make that one cut, and then like a lot of stuff comes off.
right.
Um,
Probably safer
yeah,
too.
really just see the peg and cut that.
I find the lighted pick helps more on some of these. I know we go to the scissors really quickly, but sometimes I think just identifying and creating the plane so that you can go back with your cutter sometimes is a little safer. So just something again, to pick up a forceps lighted pick to kind of just push the retina back and then dissect some of it off.
Yeah.
Yeah, that's what I use primarily. I very rarely have to open scissors these days.
Even the verticals.
Yeah, I almost never use the verticals.
Yeah. In some of our, we don't always have verticals. Like we have more horizontals in one of our sites.
Hmm. And then there was some highlight that we were just getting a little bit more peripheral.
You're doing great. This is great.
Yeah. And I think because there's detachment, like, you can't leave so much hyaloid anyways. Like, sometimes you stain again, see what you can see, and then, with the fluid flow, things can become a little bit, better visualized.
So I did skip a little bit there because there was a lot more segmentation. But essentially, that was that break that I made with the horizontal scissors earlier on. It took us a minute to find it, as Dr. Tribusava alluded to, but we used that to drain, um, at least make the best of a issue there. And so
Yeah,
then
it
we,
always gets bigger too because of all that thick fluid that's going to come out of it. So
Mhm.
yeah, it works. It's going to work out well for you.
Good
and so we just
laser.
finish up with lasering the parts that didn't have PRP previously.
Biffy, as he's doing it, how aggressive are you to get that clot of blood that's over the posterior pole that's going to annoy you for a while?
Yeah, I'd give it a try at this point. I mean, the blood gets close to the break, and that causes more fibrosis. So, I think I would give it 2 tries, 2 good tries.
And so the patient did, fairly well. They're 2200 with a baseline vision of 2100. And the macula looked actually kind of better than I was expecting after all that.
Yeah, 6 months before you know for sure. This is, you're going to get some more vision out of this. That's great. Great job, Joe.
Nice job.
Beautiful.
And I do
Well
want to
done.
thank everybody for all the guidance during Cobra for the last 2 years. It's been, a real pleasure. going through all these videos with everybody. And as Asan likes to say, this is my fourth year of fellowship. So, are you confused? Were you confusing me with Hadi? I like that's the only person I could think you could possibly have confused me with.
Wow. Are you saying that Asan thinks all bearded brown guys look the same? Okay, well there you go. That's nice to know. Let's move on to
His
the next
words.
one. Joe, congratulations.
No, Joe, you're just very memorable. I think it's a
Oh,
compliment to you.
So
I feel
sweet.
like
oh,
we've been with you for
well,
so
well
long.
done there. Well done.
Nice.
Memorable.
Good save.
Yeah, he's gonna forget about you in 20 minutes.
Yeah. Our next presentation is by our other senior fellow, Bertan Chakir. So Bertan joined us also from the Massachusetts Eye and Ear Infirmary and has been a fantastic fellow. He just won our fellow teaching award this past weekend, so congratulations.
Congrats. Nice job.
Bertrand will not be going back to the Mass Eye and Ear. Instead, he's taking a clinician scientist position at the University of Michigan. So we're very proud of him, and he's a mitochondrial biologist and a vitreoretinal surgeon. So show us what you got, Bertrand.
All right, thank you very much. Very excited to present my last Cobra presentation here, and can also believe that it's already time almost to be done with fellowship. All right, so this is a case I did with Dr. Wei. This was a 47-year-old male who came to us with a history of a bilateral globe injury secondary to an explosive device about 4 months ago. The patient was handling this explosive device to loosen soil. He was working in the mining industry. It was like this blasting cap you can see on the right side, and detonated prematurely. With this event, he lost his left hand, right eye, and portions due to the abdominal trauma. Some of the intestine had to be removed. So he was admitted to the ICU, was ventilated for about 2 months. The right eye was enucleated right after the day after injury, and very little is known exactly how much injury was done to the left eye, and that there was apparently the possibility that there may have been also an open globe injury, which was not repaired, but it was reported that he had complete vision loss in that eye. He was seen by a local ophthalmologist about a month later, like a total of 3 months after injury, with a complete hyphema, corneal blood staining, and scarring on the cornea, as well as a B scan, which looked like funnel RD and with bare LP vision. He was then referred to Stanford for a possible PPV, TKP, and PKP, or possible PPV with endoscopy. So when we saw him, obviously the right eye was enucleated, so NLP vision, left eye was LP vision, and his pressure in the left eye was fairly low. It's 6 millimeter mercury, and you can see in the picture that there was no view to the posterior pole because of complete corneal blood staining, an old complete hyphema. There was also this vertical corneal scar indicating that there may have been a possible open injury to the eye. So we performed a B scan, and the B scan, at least to our read, was concerning for funnel detachment with many membranes within the funnel, concerning for PVR, and also the eye, the choroid, as you can see, was somewhat thickened, likely due to the low pressure already. So
All of our B scans at Stanford look like this. We just repeat it over and over. Little funnel detachments everywhere.
Is that after your macular hole surgery
That's
previously, or is
basically
this
it.
a
Yes, yes.
we generate a lot of them, yeah.
Yeah.
Yeah, so the plan, I mean, obviously we discussed the patient was very motivated to have surgery given, no vision in his other eye, and he wanted to have everything done to see if we can regain any of the vision in this eye. Obviously, we discussed with the patient that there is a very guarded, visual prognosis given the, extensive findings with, low pressure eye, funnel detachment configuration and setting of trauma, which has been now 4 months ago. We discussed with him possible NLP vision after surgery, that it may be inoperable and that he may need many, many more surgeries to get this, fixed in the future. Regardless, patient wanted to proceed and for a surgical plan, so we referred the patient to our cornea colleagues because given the complete corneal blood staining, we needed to do a temporal keratoplasty. Then the plan was to do vitrectomy, then a membrane PL, a possible 360 retinectomy if necessary, and then likely silicone oil, and then at the end he'll need a PKP. And this brings me to my video. So we placed, it was a little quick, but similar to what Jonathan mentioned, cheating a little bit anterior, a little bit parallel to the iris, and then for the inferior temporal cannula, I chose a 6 mm cannula just to make sure that we get into the vitreous space and not under the retina. And then we gave it over to our cornea colleagues who took off the cornea, and then they dissected off this thick pupillary membrane, which we identified hopefully not as retina, but they took that off. And then after that, this looked more like lens material actually in the eye. So I decided to scrub in and help trying to express this cataract just with an open sky approach, just having the infusion line going into the eye and then using the cutter a little bit to help promote the nuclear pieces outside the eye, as you can see here.
You're eating it or just trying to ask?
I'm eating, sucking, but it came actually just in big pieces out on its own. It was, and then at some point we weren't sure what we're dealing with, and then obviously at that point we decided to stop, and our colleagues put on the temporary keratoplasty. Then we made sure that our cannula is actually visible, and then we started with an anterior vitrectomy, dissecting the first membrane off, hoping that it's not retina. And then to our surprise, actually.
Wow.
We were expecting the worst, but there is not a complete frontal detachment, and we're actually viewed to the nerve and to the posterior pole with extensive scarring. So we, then just proceeded with our core vitrectomy, trying to clear the visual axis um, as good as possible. And there was still a small cortex piece which fell to the back, which we'll thankfully be able to eat just with a cutter. But first, we wanted to make sure we have the hyaloid up before we do so. And hyaloid seemed up in most places, and but the infratemporal area, as you can see in a moment, had definitely still some hyaloid attached. And then we try to lift this area there, and it comes not very nicely off in the sheet. There's some remaining vitreous stands there. We'll decided to leave that for now and address that later. And as you can see, also in that area is like a large scar in the periphery, which may have been an impact site. So then we decided, so we switched flipping in the green lens. We were, seeing these like membranes just right over the posterior pole. You can see under the retina actually extensive fibrovascular scars and these subretinal bands. But we did wanted to give it a try if things come easily to remove the membranes over the macula, and that's what we decided to do and using the green lens and the ILM forceps and very gently trying to pull these off without causing a tear. And
It's like hyaloid and membrane, right?
yeah,
That's
it's
that?
probably the combination of hyaloid and membrane. Um, and then there, the superior arcade, it seemed quite adherent, kind of like almost maybe like a neovascular tuft actually, or fibrovascular tuft, and we left that for now. We also wanted to see what we can peel for the ILM to reduce the scaffold for maybe possible future
Nice.
PVR. And it actually presented itself nicely with a flap, so we were able to grab that. And we decided to proceed and peel off the ILM just over the central macula.
Hey, son, what do you think about those subretinal bands?
Accessing that, you're good luck right now. I agree with the pre-retinal peeling and seeing how it stabilizes out.
Yeah, here we
You're,
just wanted to isolate that tuft here.
yeah, I think you're looking for trouble to go after the subretinal stuff here.
And we tried to, further extend our peel just around that area of concern where that, fibrosis is, but it didn't come quite easily, so we left it alone. And then we wanted to, get our attention back to the area where we were a little concerned, where the hyaloid still seemed attached. He had tried to lift it with the ILM forceps, and I think it was hard to see, but I was a little concerned that I may have crossed, even with like just pulling on that vitreous there, that may have been created a microbraid, but we weren't actually entirely sure. And as you can see there, there's like this large area of fibrosis or possible impact site, which looked like it was causing traction to the retina, and on the edge of that, the retina seemed already lifted. So we were concerned about that area, and this is just the area I was a little concerned about. But we did still wanted to get the hyaloid off as much as possible there. So we took the flex loop and try to extend these remaining hyaloid sheets off that area. The retina appeared also thin. And we grew more and more concerned that the area actually may also be a little lifted. So we decided maybe just to barricade that with laser and see if we can get good laser uptake and see how that looks. But as you can see in the center there, I wasn't really able to get a good uptake. And with the laser, actually more kind of micro breaks happened. It was like a little like a mothy, rotten kind of retina. And as you can see, it's now starting to move. So then we made the decision given the area of traction on the periphery and the retina easily now lifting off under fluid, we decided to create a small focal retinectomy and outlining that with our endodiathermy.
So before all the peeling and the laser, the retina was attached.
Um,
So you like to your eye, like your naked eye with the scope.
Yeah, initially I thought initially it was, maybe Karen, Dr. Way sees that differently, but initially I thought it was attached, but maybe I was concerned right where the big scar was on the periphery that it seemed a little lifted there. Yeah,
Mhm.
It
but
could
certainly
be
not like this
contracted
initially.
there,
So
right?
something happened along the way. It probably caused some micro tears or tears while peeling the area. And what I also realized when you do TK with the temporal keratoplasty, the fluid dynamics are very, very different. You can see how much that retina is flailing and is like very violent. So in retrospect, I probably should have put down a little bit of PFO there to help me stabilize that. But that's certainly different compared to a normal case where you have normal fluid dynamics in the eye.
You can also argue that this posterior relax somewhat separates that anterior fibrotic material, not all of it, but it does kind of separate it a little bit. Because one of the issues that you're going to have is if you can't get all of that anterior stuff off and you don't have a buckle and etc., it's going to contract anteriorly, and that messes your ciliary body, but it also can, then lead to a more posterior detachment. So you didn't completely, isolate it all the way around, but at least in some areas there's going to be a little gap between that fibrosis and the back edge of your retina. Maybe that'll be helpful.
Yeah, that was our thinking as well. Thank you.
Yeah, I was gonna say, I think that retina nasally was very thin, and then when we lifted the hyaloid in that area, it essentially kind of loosened the retina underneath.
Yeah, refresh a little bit the
Now you're
retina.
going to go after that subretinal band? Oh,
Well, I mean that is right on the macula, so
right there. You're so close.
we wanted to leave that alone. We felt the macula looked great. And then we placed PFL, but we were not really happy with that at one edge. It was just too sharp of a turn, as I learned in
Mm.
fellowship. You do want to round these edges out. You don't want to have, sharp turns in your retinectomy edges. So, and we didn't want to go anywhere beyond that because the retina was attached and it was really hard to detach that retina and do more. So we felt that was enough, and then we applied laser to the edge, and then we did decided to put silicone in a oil in as our tamponade. So we did a fluid air exchange here. And what I realized quickly also when you have a temporary keratoplasty on that you fog up very, very quickly. And that makes the step actually much harder than I thought. And that's like also, again, these weird fluid dynamics in there. But a good trick here is actually to think about is putting some peel on the back of the TK. And then that really clears up your view. And then as Dr. Sivastava said, like I like to walk around the edge of the retinectomy and try to drain as much as I can. And then drain over the optic nerve a little more and put in some more laser in because then you have a better peripheral view. Then our cornea colleagues helped us with putting in the retention sutures. We talked about it today already that many of you don't you do them anymore because they're a little help. And then they proceeded with their graft. And just, I don't have the rest of the video also because of time problem here. We topped it off with oil at the end and then closed up shop.
What kind of oil did you use? 1000 or 5?
It's 1000 centistokes. And
Plans
then,
for removing the oil?
uh, yeah, that's a good thought. Not for now, but so given that things are looking better than we expected. But this is our post-op week 2 picture. Unfortunately, the patient is coming in this week. I was hoping he was going to come in last week so I can give you guys some more updated pictures. But at this point, he looked attached, and vision improved to 2400 with a 12 D lens. So that was good. But the IOP remains a concern and very low. And that brings me to taking out the oil. I'm just concerned if you take out the oil that this eye may even get more hypotenuse, so it may need even an oil exchange and maybe doing, we maybe should have thought about a 5,000 Cinestock oil from the get-go, actually, in retrospect.
What a heroic job. That's I mean, he must be thrilled that he can see something out of the side. That's
Yeah,
awesome.
he's super. Yeah, he was very depressed, obviously because of his vision situation, and he's very happy that he regained some of his vision back.
I
And
also think you point out something here that, a little less might have been more there. You were aggressive because you were there. And so sometimes, one of the take-home lessons is, this retina was down, was attached, you eat for weeks and months right afterwards. And just
right.
our manipulation, the more manipulation you do. And sometimes it looks like you should go after something. And it's hard to know. It's hard to know if that would have happened regardless. But
Yeah.
sometimes a little less might have been more there.
Yeah, I thought about this a lot, and in retrospect, I wish I would have been a little bit maybe just leaving this area all alone after just
Yeah.
leaving vitreous strands on there because, as you said, has been attached for 4 months. Like if this would have been already totally detached, if this was going to detach.
But I will say that it's in the midst of like a tough case when you have to make that decision for like the focal retinectomy when you could have maybe just left it with laser. I think that was a bold move actually,
Mhm.
and you could have easily just said I'm not gonna we'll just leave it and come back and fight again. But I think that was aggressive in the right way.
Yeah. So I also want to thank Karen, Dr. Wei, who was the mentor on this case, who was a big help, and all my surgical teachers, in particular Dr. Pan, Dr. M, Dr. Rahimi, and obviously my co-fellows and Dr. Jonathan, who've been training with for so long. So we'll see how I will do without him, but I guess I'll survive somehow.
Sounds like you guys are going to need to call each other often, or at least
I
text
know,
each other
right?
I
often.
think
Yeah,
so.
we're
Yeah, I think
we're a
so.
text message away, Bertin. I'm sure we'll be getting them from you.
I don't think he's going to text you, man. I think he's texting Jonathan.
It's
No,
possible.
I'll text Dr. Rahimi as well. All right.
Congratulations. Great work.
Thank you.
Our last fellow to present, Dr. Ferris and Taki. Ferris is heading back to Montreal. He trained there, did his residency at the University of Montreal, and then was actually at Moorfields, did a fellowship with Pierce there, and has joined us and did his VR. He'll be starting up back in Montreal and actually staying on in Cleveland as well. He's going to be doing part-time research here as a consultant. So we're very excited to actually keep him. Ferris, take it away, man.
Thank you so much. Can you hear me well? See my screen?
Yes.
Fantastic. So this is a case I did with Dr. Danny Mamo. This is part of a series of complex macular holes we did together. And I want to thank him for all the tips he's given me and how we approach this technique. You'll see we built this together. So this was the case of a 63-year-old female with a persistent macular hole, operated twice before, referred to us for a second opinion. High myopia, axial length 29.96, history of myopic CNV, had the macular holes that measured 280 microns. But if you actually correct for her axial length, it is in reality slightly bigger. This is how her OCT looked like. There was some epiretinal membrane. So going into this case, we were thinking we were definitely going to stain and try to peel any residual ILM. We elected to do an amniotic membrane graft, which is the approach we refined over time, and I'll show you some of the tricks and tips in our approach to placing that. But you could have certainly just tried to peel ILM and maybe just put gas, but this has failed twice before. You could try subretinal blebs, but that's not the typical anatomy that people think of. It's not flat open. So there are a few things you can try. So the way we approach this is 23 gauge setup. We typically open where your dominant hand is, in our case, the right hand. We open the conjunctiva and then insert the 23 gauge trocar parallel to the limbus. Because this is a trocar you will remove when inserting the amniotic membrane. We, from the get-go, start with a 25 gauge chandelier because this is a bimanual technique.
Paris, why do you feel like you have to go through Byers sclera to bring in the amniotic membrane? You not put it through the cannula?
You certainly could. In some of the cases we have, but as you'll see, so you want to fold this like a taco, and you want to do your best to try to preserve orientation, to have the chorion down. We're not sure it really matters, but people describe that possibly it helps the macular hole close better. So because of that reason, we think you induce less trauma or folding or squishing on the amniotic membrane. So that's the reason why we do that.
I mean, another
BNL,
option, since you're going
BNL,
23s, you can also use a smaller forcep. Like you could take a 25 or 27 forcep, so you're not like so tight in the cannula, but taking it out, it's just awesome too.
BNL
Uh,
also makes a nice valved cannula where you can actually remove the valves. So we did one of these cases at Metro, and we actually popped off the valve, if I remember correctly. And
yes.
yeah.
So we are some of the instrumentation we are using is 25 gauge, despite using 23 gauge trocars. So one of the things you want to do, this sounds silly, but this is the case where you want to really visualize really well. So if you have a posterior capsule opacity, just open the capsule. And you want to ensure the vitrectomy is complete. This patient has been vitrectomized twice before. You can see the chandelier. And then you want to stain. We used ICG here for to stain for residual ILM and epiretinal membrane. We had doubts that there was residual ERM based on the preoperative OCT. So, you could peel with a flat lens, you could peel with a green lens. I like to peel with a green lens usually for most cases, but in this case, actually, using a flat lens was really useful because this is a highly myopic eye with pigmentary changes, and it was really hard to see good separation between the layers with a green lens. So using a flat lens is preferable, at least in my experience. So some areas stained decently well, but some areas you're relying really on, I'm peeling the LM, I see some movement somewhere, and then, I think there's an ERM and I peel it. And then we, prepare the AMT. We try to mark it for orientation. So you can draw a letter like an F or an E. You need to draw really, really well to be able to mark that to avoid, just the marking going a little bit everywhere. You trafine, we do 6 mm, but other sizes have been described. And then you fold the graft. You ideally want the sticky side to stay down, so the chorion side to stay down. So you fold it like a taco. And then we spoke about this. You remove the trocar. There is, whether you like it or not, there is some squishing of that membrane that will happen. We use a handshake technique to exchange the graft. The reason for that is we want to put the trocar back. This is a case where fluidics are really important, so we put the trocar back to reduce flow. You want to try to unscroll the graft, and then you use two instruments. So you're gonna hold the graft with ILM forceps. You could use a flexible loop as well. but the graft could fly, and you use a dual bore to inject PFO. And this step looks easy in this case, but in other cases, we've had trouble where the flap will actually slip to the edge of the PFO. So you really need, a specific velocity, I would say, of injection to be able to just flatten it with avoiding the graft to scroll up. You don't need a lot of PFO. You could inject to the arcades or maybe more. And then here you want to try to position the graft on top of the hole. It is a big graft, so it is forgiving. You can use a flexible loop, but a flexible loop could stick to the amniotic membrane. So in some of the more recent cases, we started using a Tano membrane, a scraper, and it tends to stick less. So intraoperative OCT can be useful to visualize graft dynamics in different under different tamponade conditions. We published a paper recently on that. As you would expect under PFO, you have the least amount of fluid between the graft and the retina. But in this case, we're not thinking of leaving PFO medium term, so we will go to air at some point. So we do go to air. In the first case, Dr. Mamo has done, which I was involved in. We did a direct PFO oil exchange. Personally, it's not something I've done once. So my comfort zone is to go to air. So that's what we did here. So as you go to air, it's really important to try to be meticulous with your fluid air exchange. So you want to get the fluid so you have three phases here. You have air, you have fluid, BSS, and then you have PFO. So you want to get rid of as much fluid as possible. And we do this back and forth, lowering the PFO and then removing as much fluid as possible.
Asan, what is your experience with adding Helon or other viscoelastic to hold down the flap, the graft?
Talking to the wrong guy. I don't believe in grafts. No offense to this case. It's a beautiful case and it's a beautiful technique. I just feel like our field played so many games with these, different ways to close holes, and I don't think it ultimately matters. So I don't do it. Anybody who needs a graft, I send it to my partner, Dr. V.
Yeah. I mean, I agree. Those techniques will look good anatomically, maybe at the end, but you always need to ask the patient, are you seeing better? And, that's not always the case. So here, you can use the flex loop to reposition or keep the graft in place as you're removing fluid. It is quite challenging when you're doing this with your non-dominant hand and also, keeping track of two instruments at the same time. But one thing we've shown is that if you try just to go to the nerve and then take the PFO down and take any residual fluid, you will still have subgraft fluid. And if you have subgraft fluid, theoretically you can have increased risk of slippage after the surgery in recovery, basically. So if you are meticulous with your fluid air exchange, which means being very slow and deliberate of going at the edge of the PFO and then going to the nerve, then you reduce that fluid and theoretically you have less slippage. And then we do air silicone oil exchange. One of the things we thought about is if you lower the IOP, you can indent the eye more. So you can drop the silicone oil on top of the graft rather than on the superior retina and then slide the graft. You can do it under direct visualization as well. And then after you've injected silicone oil, you can reposition the graft, which you'll see shortly.
This case didn't have a very prominent um, posterior staphyloma type
Hmm.
appearance. But if that were the case, would you still use oil?
If there was a staphyloma, would you still use oil
Yeah.
as opposed to just gas?
Yeah.
Yeah, you could still use oil. I mean, one thing I'm really curious about in highly myopic macular holes is macular buckling. I see people describing that. This is something I'd love to learn, but I don't think we've modulated whether which tamponade to use. Why are you asking this question?
Well, if you look at the um, when a oil bubble is formed, it's that perfectly round bubble, and if you have a staphyloma and you're being so meticulous about the fluid under the graft, potentially you could have a little space between the back of your bubble and the surface of the
Hmm.
retina, especially these long eyes. That's why, sometimes gas is better in those posterior macular hole detachments. It doesn't look like that here, but it is a consideration, Paris.
Yeah, it's true. That's a great point. We didn't really think of that in this case. It is true that this patient didn't have a posterior staphyloma, but you're right. This is one interesting point.
I think gas, though, would be difficult to position the patient because wouldn't you have to theoretically keep the patient positioned in such a way uh, so that the amniotic membrane does not become, won't just float off?
Yes. And the positioning we did for this patient is to stay flat on the back for about half an hour in recovery, and that's the first, I think, one or two cases we did, we weren't as meticulous about that, and the patients, waking up from anesthesia, or if they're under MAC and the anesthesia team just lifts the patient up, and you're like, oh, we forgot about that, and the grafts could slide. So you really have to be meticulous and think that this patient needs to stay flat on the back. At least we're thinking that maybe some of function of the RPE will keep that graft suction down, and then whenever they're awake and ready, to be face down, then they need to be face down typically 3 days. And then this is how this patient looked, I think, at week 1. Um, and then this is how her OCT looks like with the graft on. And then after then at 6 weeks, you can remove the oil and then peel that membrane off. Those membranes can contract. And, in this case, the macular hole closed after removing the amniotic membrane.
That's like perfect positioning of your graft, like in your previous picture. It's really very meticulous.
They don't all look like this. So it is a difficult technique that has a lot of variability, and it doesn't always look like this.
Maybe yours always look like this, but really good.
Oh, this is all the N of 4. They all look like this.
That's fantastic. Because I've seen that graft like in all different places after I've placed it down. So this is very good.
That's it.
What's the vision? So
Doesn't
far,
matter. Doesn't matter.
no,
Doesn't-
Joe is winning at 2,200. Everybody else is like count fingers, 2,400. This is
Vision
retina.
is 2100.
Oh, Ferris wins.
I,
Best
I
visual
think
acuity.
I think Ferris was just going to make it up whatever Joe's was. But
It
he's
was
going to say it's
20.
better.
Yeah,
Yeah.
100.
He's using the metric system. Ferris,
Yes.
great job. Great job.
Thank
So
you.
when
Thank
do you
you.
take the oil out? Sorry, to just say again, when do you
You
guys
did
take the
6
oil out?
weeks, right?
We
6
did
weeks.
6 weeks. Yeah.
Got it. Awesome. Congratulations,
Yeah.
everyone. What a great job on this. Can't believe we got through another year.
Yeah, look at these kids. They've grown up so much. Like, from where they started. This is really impressive. And so we appreciate the fellows for, sticking it through with all of us for 2 years, but also like for sharing their surgical learning. It's not easy to share cases that don't always go great and decisions and gosh, we're like kind of critical of them, but yet they still come back each time, and we appreciate them and very proud of them. They're all gonna do great to take care of their patients, and that's the end game here.
Yeah, it's great to see kind of the videos from, yeah, I hope the fellows get to look at some of the videos from their first Cobra to now and just get to see the group the get just to see yourself grow. It's great, and you all have done a fantastic job.
I
Take it
think,
home, Prithvi.
Thank you.
yeah, Jar, do you want to put up our slides? Ferris, can you come off? Thanks. So we're grateful to the our supporters with Bausch and Lomb who've been great to have us continue, and also to the iVista team. And the two of them have put together our upcoming Cobra After Dark, which will be on October 9th, Friday, after the first day of Retina Sub Day in New Orleans. We're at the Republic NOLA, which is just a short walk from the convention center. So please register now. It's going to be a good time, great cases, good fun. Tell your friends, other fellows, people that are interested in retina. It should be a really good time.
You can get a ride from Prithvi on his e-bike, and
I am going
he'll
to,
just
yes, I
take you
will
back and
bring
forth.
everybody. I will bring anybody from anywhere to Cobra After Dark. That's
Yes.
my only job. Sunil, when do we meet again? In
I
August?
believe we go with our next one in August. I don't know if we have our exact date yet for our August one, but we give everyone the summer off, give our fellows an opportunity to to find some great cases for our for current first years to share with us in August. We're looking forward to seeing everybody. Congratulations to the seniors one more time, and to the probably congratulations to the mentors who have taught these seniors and have just a slightly more gray hair. Maybe their hypertension's a little bit worse, but somehow you made it and survived. Congratulations. You graduated another set.
Way to go. Thank you very
All
much.
right. Have a great night, everybody. Take care.
Good night. Great job.
I mean, based on Alex's theory that you lose your hair, Prithvi,
Uh,
it's not good.
I've trained them the most that
You felt it the most. That's
I
the
know, right?
case.
Seriously.
I understand.
They're all really
That's
good. It's all really good.
Oh, they're great cases. Holy cow. I mean, how much trauma? What are you doing? Punching people left and right? And
Get cases somewhere, man. Like, we're